think then we go on to Dr. Simar for his talk on interpreting ERG and VEP.
Thank you, ma'am, and thank you to Dr. Suresh and GMCH for this opportunity. So we'll be talking about electrodiagnostics tests. It's a little dry topic, but whatever we talked till now was structural imaging of the retina, and what we are going to talk now is actual function, how to detect function, whether the patient is actually seeing or not through that structure is what electrophysiology is going to tell us. So it is the only objective assessment of functionality of the entire visual pathway. The patient can tell you he is seeing something, he's seeing low or he's not seeing in the dark, but that is something that is subjective to the patient. Electrophysiology is the only way you can detect that objectively. Symptoms not matching with the signs is another time when you would want to do electrophysiology. Nystagmus, wandering eye movements, low vision in a child, you don't know what is happening, you want to do electrophysiology. Inherited retinal disease is obviously an important condition. And to check the integrity of the visual pathway in case of media opacities, in case you want to decide you want to intervene or not in that, you will need electrophysiology. Monitoring drug toxicities like HCQ toxicity, and monitoring your response to treatment in a lot of cases. So if you are doing electrophysiology, this is something that you should absolutely know about. That is ISCEV, that is the International Society for Clinical Electrophysiology of Vision, which lays down guidelines that make these tests standardized. If we are doing something here in Chandigarh or somebody doing something in Germany or in USA, the guidelines tell you how to do a test, how much exposure to give, how much light to keep, how much dark adaptation to do, so that your tests are comparable. If you are doing something here, it can be interpreted by somebody else sitting somewhere else. The machines, the light intensity, your illumination settings of the room, the time you want to dark adapt a patient, light adapt a patient, everything is given by them for each of the electrophysiology tests that we may talk about. So just getting a gross overview that what all tests do we have and what do they test. So it's the entire visual pathway that we want to test, and each of the tests something specific in the visual pathway, and each of the components of the test further test something specific. So if you know that, then you can interpret these tests better and know what is the problem in this. So this is the retina as we know, the multiple layers of the retina, the RPE, the outer retina, the inner retina, the ganglion cells, and then the optic pathway through the optic nerve, lateral geniculate body, and to the visual cortex. So if you start from the start, the RPE, you have the EOG which tests the RPE. So that is one test that is specific to the RPE, but it does not mean that it can be taken alone. The RPE is going to function only if your photoreceptors are functioning. So whenever we are talking of any test, you have to do all the tests and then narrow down to one that, okay, this one is abnormal, so likely the abnormality is lying here. So the RPE is tested by the EOG, and then comes in your retina, the whole of the retina, that gets tested by your full field ERG. Full field ERG means the whole field, means you are going to test the entire retina, means you are going to dilate the patient and then you are going to test the patient. Alright, so full field ERG kind of tests the entire retina. And then if you were going on to multifocal ERG tests your central retina, the similar responses but from the central retina. So you need a patient that is undilated who can fixate on a particular object, and then you do the tests. And then when you come on to the ganglion cells and the optic nerve, that is tested by your pattern ERG. So the ganglion cells specifically, if you want to test, you will need the pattern ERG. Again, it is a test which requires fixation, so the patient should be undilated for this. And then going on further, once you have the optic nerve, this whole pathway is tested by your VEP, that is visual evoked potentials. So if you have a problem in your cornea, you are not wearing proper glasses, you have cataract, you have a retinal problem, you have an optic nerve problem, anything will cause a problem with the VEP. So VEP is the most non-specific test that you have, but it tests your entire visual pathway. But if you have tested everything anterior to the optic nerve with all the tests that we discussed earlier, then yes, your VEP is kind of focusing your problem onto the optic nerve or the pathway that is going beyond. All right. So just quickly look at these one by one. The visual evoked potential, this tests the functionality of the whole pathway. It is sensitive, but it is non-specific, as we talked about. It is a good initial screening test to start with, and a good pattern VEP recording tells you that the patient has at least something around of a 636 visual acuity. So pattern VEP, again we are doing it undilated, and for all the pattern tests we are using a monitor to stimulate the patient, while for all the full field test we are looking at a GANS field, something like your visual field testing module, which tests your whole field. So here there are 3 electrodes. One is the reference electrode that goes right here, your active electrode that goes at the occipital cortex to test the signal that is reaching there, and the ground electrode right at the top. All 3 are gold cup electrodes, and you will get 2 waveforms which are important, the N75 and the P100. There are different types of stimulus that you give in a pattern VEP. It can be a pattern reversal, that is the most common stimulus that we give, or a pattern onset offset VEP. Onset offset means the pattern is coming and then blank, coming and then blank. So that is given whenever the patient is not fixating properly. He has nystagmus. He has problems in maintaining steady fixation. So then a pattern onset offset may be used, or a flash VEP, which can be just a very basic screening test. The patient is absolutely not fixing. You flash his eye with a light and see if you get any waveform or not. So that's a very gross test that you do. And this is the waveform that you get. N75, as it tells you, comes at about 75 milliseconds. The P100 is supposed to come somewhere around 100 milliseconds. So you want to see the peak time, when are those waveforms coming, whether they are coming at when they should be, and you want to see the height of the waveforms, whether their amplitudes are normal or not. So these are the 2 components that you would like to see. So just some points to remember: it records the responses from the entire visual pathway. Readings can be affected by anything that is affecting your vision, so it is very non-specific. To pinpoint a cause of reduced vision to the optic nerve, you need everything else to be tested and then say that rest everything is normal. It is just the optic nerve. Retrochiasmal lesions will need a multi-channel VEP. So what I showed you was a single channel. You had just one active electrode. But if you want to test for any retrochiasmal lesions when your fibers have kind of decussated, then you need multi-channel VEPs to record from the different, both the occipital lobes separately, and then see how much signal is going towards each side. So we are not going into the details of that, but that's helpful in conditions like albinism and neurological conditions. Coming on to the full field ERG, that is the most commonly used test. So electroretinogram, you are basically testing the retinal potential. So you need your electrodes to be as close to the retina as possible without actually going into the eye and going to the retina. So it should be as close to the cornea, touching the cornea, that is possible. So that is your active electrode. And then you have your reference and the ground electrodes to measure that. And those are the different kind of stimulators that you use. That is the pattern pattern ERG. Again, like a pattern VEP, you have a black and white checkerboard pattern. You have a multifocal ERG, which kind of localizes your lesion with pattern sizes that are variable according to the area that you are stimulating. And then you have the GANS field that is stimulating your whole of the retina. These are the various electrodes that we use, but for practical purposes now just 3 are actually available in the market. The gold cup is the one that you use for your reference as well as your ground electrodes. The DTL electrode is the one which is placed just touching the inferior margin limbus of the cornea, and that is your active electrode. It is the most sensitive of the lot. And for some of your uncooperative patient, pediatric patient, you may choose to use skin electrodes, but then your amplitudes will be about 1/10 of what you get with your DTL electrode. So these are the 3 main that we are using. Rest of them were used historically but are now no longer available. So this is a basic waveform that you get from the retina when you stimulate in a full field ERG. You get a negative deflection, that is the A wave, and then you get a positive deflection, that is the B wave. So the A wave is very specifically coming from your photoreceptors. So within the retina, when we talked about, we were talking about the retina as a whole. RPE was EOG, the ganglion cells were with the pattern ERG. The retina is further segmented into inner retina and outer retina. The outer retina, that is the photoreceptors, are tested by your A wave. So if you have a A wave, means your photoreceptors are functioning fine. And your B wave, that is the positive deflection, that comes from your inner retina, that is your bipolar cells. And anything between the A wave and the B wave are your amacrine cells and the horizontal cells, and those come in as oscillatory potentials, which come on the ascending limb of the B wave. So those are signals coming from there. So this is the ICEV minimum standard of full field ERG that you need to do, which gives you the different flash intensities with which you test the patient. I'm not going into the details of the testing. You need to dark adapt the patient for about 20 minutes before, and then conduct the first 4 tests, and then light adapt for 10 minutes, and then conduct the rest of the 2. But those are the intensities of the flash that you give, which will be progressively higher. The important thing to note is the DA 0.01, that is a very dim flash. So it tests only your rod function. There is no cone function involved here. It is such a dim flash. The DA3 and the DA10, which are more brighter flashes, they have inputs from both the rods and the cones, but still majorly the cones, because the patient is dark adapted. And then as you go into the light adapted responses, you get the response from the cones only, because now the patient is light adapted, the rods no longer function. So the flicker ERG, that is the 30 hertz flicker that you are seeing, that is basically testing the how frequently can your cones function. So you're giving flashes of light which are coming very fast. So they test your strength of your cones, and the basic function is given to you by the LA3, that is the light adapted 3. So I'm just going to skip this. The multifocal ERG is just your central 10 to 20 degrees of the field that we are testing. The good thing about multifocal is that it gives you localization of the lesion, and because these the stimulus that you give is very specific to that particular area, and you can monitor the patient on multifocal ERG, especially for drug toxicities and those. These signals that you get, they are computed, they are not the actual waveforms, so they don't mean actually anything, but they just tell you whether that signal is coming from that point or not. And you get this color map showing how much signal that you are getting to representatively show it to the patient. So just you can see how it can localize the signal, whether your center is functioning, your sides are functioning normally, or one particular point, and then you can monitor the patient accordingly with that. The pattern ERG, again, as I told you, tells you about the ganglion cells more than what your full field or your multifocal were telling you about. So this has the 2 main components, the P50 and the N95. The P50, the positive component, is driven by the macular photoreceptors over here, and your N95 component is driven by your ganglion cells. So if you have your P50 coming and you don't have a N95 coming, you know your ganglion cells are affected. But if you don't have a P50 coming, means your photoreceptors are not functioning at the posterior pole. The N95 will not come, because you can't have a transmission if you don't have a signal generated from the photoreceptors. So the N95 component of your pattern ERG kind of localizes your disease to the ganglion cells which are there in the papillomacular bundle. So this is just, again, I'm just going to come to a couple of examples to show you the utility of that. And coming on to the last one, that was EOG that we have left till now. That is basically to record the potential from the RPE. That's a very low potential, and it's recorded by a variable source of light that is shifting from left to right, with the patient also moving his eyes from left to right. It's a little lengthy test, and what we always remember about it is the Arden ratio that we get. That is the ratio of the light dark trough to the light peak, and that gives us information about the RPE, typically vitelliform disorders like Best disease. So in that, I'm just out of time. I'm going to show you 2 examples. I'm not going to show you too many of those examples. All right. So this is a patient who comes to us, 9-year-old female, low vision in the dark. All right. What do you see in the fundus? Do you see any abnormality in the fundus? Except for that it's a bit tessellated, myopic looking fundus that you see. There was no other abnormality that you could see. You saw autofluorescence earlier, Dr. Raman showed you. This is kind of a normal autofluorescence, no abnormality is here, but the child is very specifically telling you that I can't see in the dark. All right, you get a OCT done, maybe we are missing something. The OCT layers are all intact. So the structure is absolutely normal. We saw 3 things earlier. The structure is absolutely normal. There is no problem here. So probably the child is lying with what we would think, but you get an electrophysiology done. The patient has come to you with a complaint. This is the dark adapted 0.01 and I have just put in the normal along with for reference. There's no normal along with here. That was a different one. So what do you see in the dark adapted 0.01 ERG? Do you see a B wave as we discussed, which tells you about the rod function? So there is no B wave. So means the rods are not functioning in this patient. The child is not lying to you. What do you see in the dark adapted 3.0 and the dark adapted 10.0? What you see is a negative deflection of the A wave and then an almost negligible B wave. All right. So what does that tell you? There is a signal that is coming from the photoreceptors, but your inner retina is probably not functioning correctly. All right. So this kind of ERG, which is called as an electronegative ERG, is very typical for congenital stationary night blindness when you get it in the setting of a very normal fundus that you were seeing in this patient. So this kind of, and you can see the cones functions which are functioning normally. You are getting a A wave, you are getting a B wave, and you get the genetics done and you prove your congenital stationary night blindness, which is very satisfying to tell the patient that yes, you have a problem in the dark, but probably it's not going to progress further, and yes, we have kind of proven your problem. And just a last example that I am going to, which was actually for you, but we are kind of out of time. So this is Best disease, again Arden ratio reduced, nothing much in that. So again, you have a 49-year-old patient who comes to you, complains of low vision in the dark, same complaint. So this is a very common complaint that patient comes to us with. When it's RP, it's very in your face RP, but there are some patients who we cannot diagnose clearly like that. So he comes to you with complaints of low vision in the dark. He is 6'6", everything looks normal. These are the fundus photographs of the patient, again looks fairly normal. Left eye again looks normal. This is some bit of pigmentary disturbances in the right eye autofluorescence that you see. The left eye autofluorescence absolutely normal. And this is the OCT of the right eye and this is the OCT of the left eye. Again normal. Patient is 6'6", no problem, but the patient says he can't see in the dark. So again you go to electrophysiology. This is the dark adapted 0.01 ERG that you get. Again no B wave. So the patient is not lying to you. He does not have rod function present. All right. This is what a normal B wave would kind of look like. So this is what your normal should be like. Dark adapted 3.0. We just saw something in which there was a A wave but no B wave. But here what you are seeing is both the A wave and the B wave are kind of symmetrically reduced. Both of them are reduced. So there is a lack of rod photoreceptor function that is there, which is again there in the dark adapted 10.0. The light adapted function is a little reduced but still present in the patient, and these complaints are mainly for the dark. So what do you think this is? Anybody, any guesses? Loudly, anybody? No? So in this case, when you are seeing a kind of a normal fundus, but you did not get that electronegative ERG, this is kind of pointing towards a nutritional deficiency, like a vitamin A deficiency, which can cause this kind of problem. So when we took a retrospective history, the patient was a known case of chronic liver disease with liver cirrhosis. We got vitamin A levels done, which were undetectable, less than 0.02 milligrams per ml. Managed with vitamin A supplementation, and this is the follow-up that you see. This is about 6 weeks apart. You can see the appearance of the B wave, which was earlier not at all present, and similarly in all other functions you can see improvement in function. So electrophysiology kind of helps you document the function as well as look for the improvement of the function. So electrophysiology, just the last line to say that electrophysiology is the only truth. It gives you functional information. So anything that you are seeing on electrophysiology is the truth. Make rest of the things fit into electrophysiology rather than trying to make electrophysiology fit into what you are thinking in your mind or what the patient is saying. Thank you.
Thank you, Dr. Simar. It was a very exhaustive and very interesting talk, because we don't get to hear about this often. Not many people do it. So I have one question. We see a lot of babies who are like have cortical visual impairment, right?
Yes, sir.
And especially the preterms also. So how early can we do a VP test in those?
So you can do a flash VP test fairly early, but the visual pathways, the values that we use for adults are not really applicable there. For children, whenever we are doing a electrophysiology, it's a yes or no answer. Waveform present or not present. Nothing more than that. We don't try to quantify that, whether it is the waveform is reduced or not. We are just looking for yes, waveform is present, no, waveform is not present for children.
Up to which year of? Up to,
Till about 2 years of age.
Till about. And
Till
how
about,
early can we do that?
yes, sir.
How early we can do
You can do it in a preterm, sir. It will give you information whether the signal is going to the cortex or not.
Okay.
But it won't. You can't quantify that signal whether it is normal or not.
Okay. Okay.
Same stands for full field ERG. You can.
Ma'am, go ahead.
Right.
Thank you, Dr. Simar.
Thank you.